Alan, talk a bit about yourself and talk a bit about this talk and your connection with the history of anaesthesia before we'll go to sleep.
Right. Well, I qualified as a chemist at Salford in 1969. In 1966, did a PhD at UMIST in organic chemistry. And then about 20 years ago, there was a joint meeting between the RSC and the History of Anaesthesia Society. And I noticed there that the, dare I say, the anaesthetists were not awfully strong on organic chemistry. So I thought this is an interest I can perhaps expand. So I joined the society, and in a few years' time, I felt confident to give the odd talk on halothane and other anaesthetics. One of the leading lights of the society of the time was David Zook, whom I acknowledge in my penultimate slide. And he was a polymath in the history of anaesthesia and keen on the history of chemistry. So we bounced ideas off each other for a long time. Basically, had he not heard of anything I was talking about, then there's a good chance that nobody else had. So I would then investigate it further. And this talk, which is on quinine urea as an anaesthetic, was first discussed with him about 5 years ago. So
Okay,
I will
Alan,
now try and share my screen.
Okay, Alan, bring up your screen. It's going to be about urea and quinine as a possible anaesthetic and probable where it's found. So, Alan, you've got your screen, put it on.
Can we see a picture now of me aged 10 doing chemistry at Leighton Primary School, assisted by my friend David Evans. This came about because 2 years earlier, my parents, when I was aged 8, bought for me as a present a Lots chemistry set, a picture of which is on the screen there. 2 points about it. First of all, it's curious that this formative chemistry set was marketed by a brick manufacturer. And the second point I will make is that the contents of the box, as depicted by the picture on the front, didn't match. It was a selection of test tubes and chemicals. I don't even know if it was a spirit burner, but it started me off in a career of chemistry, which some 70 years on is still proving satisfying. So I began as an 8-year-old, adding this to that, according to the instructions in the booklet, and getting some pleasure from the chemistry. But after a while, the booklet was exhausted. So what do you do then? Well, in the spirit of discovery and with a certain naivety, you start adding this to that, combinations not mentioned in the booklet, in the hope that something might happen. What I was expecting, I'm not sure. A flash, a bang, a smell, I don't know. But usually you got a brown sludge that sometimes smelt of H2S. Because chemistry doesn't work like that. Chemistry, you normally know what's going to happen because you've got a back knowledge of the reactivity of the various components you're going to be adding. The exception that occurred to me was Leo Baekeland, who in 1909 hit upon the reaction between phenol and formaldehyde and produced a dark colored resin, which he spotted was moldable, and that gave us bakelite, a plastic that was around certainly for half a century. But as I said, our chemistry really is built on other people's chemistry as ideas come together. So the chemistry that I describe here is essentially unaccidental. It is based on a foundation of what went before. Now we'll move down. Similarly, in pharmaceutical chemistry, ideas which were unaccidental were few and far between. And I suppose the exception would be the penicillins, which were discovered in 1929, exploited in the 1940s, and then by virtue of the chemical tweaking of the molecule, we had species like benzyl penicillin, amoxicillin, ampicillin, and all the rest. I now turn to local anesthesia, and I turn to cocaine. Now, this is, or the leaves that yield cocaine, look not unlike privet, and the native South American Indians would chew them, and that produced a very mild euphoric effect, a stimulating effect. And it was later found in the UK that if you take these leaves and steep them in a cheap wine, sugar it, you've got a very nice stimulating wine, and this was very popular from about 1875 to about 1914. It was rich in cocaine, enough to give you a slight high, and the people who drank it in that area were happy to advertise the fact to one and all. Queen Victoria, various popes, Thomas Edison, and all the rest used to enjoy their nightly tipple of this tonic wine and enjoy it. It was also, until about 1915, an ingredient of Coca-Cola. The fact it gave us a mild euphoric effect, a mild stimulating effect, was interesting, and the chemists wanted to know more about it. But the problem was getting the leaves in the UK or into Europe was difficult, because in the 6-week voyage from Peru or South America, they would shrivel and become moldy. However, the advent of refrigerated ships used for the meat train gave us the possibility of large amounts of coca leaves in this country. And the table on the graph on the right shows the vast increase in tonnage of coca leaves coming into Europe. And on the left, I've got some key dates for us. We've got the isolation of cocaine in a pure state by Gaedcke in 1855. We've got an analysis in 1863, that was the correct one, C17H21NO4. And then in 1894, we've got the correct structural formula produced by Wolfstetter. And there is Richard Wolfstetter and his formula of cocaine. We notice that there is a tertiary nitrogen in the molecule and 2 ester groups, both of which are important in its chemical and medical properties. With large amounts of cocaine being available from these ships coming across and improved processes of getting it out from the leaves, it became a very popular medicine of the last quarter of the 19th century. Sigmund Freud used to use it to wean patients off morphine addiction, which sadly made his patients both addicted to morphine and cocaine. It was used to treat indigestion. It could suppress appetite, and I came across one reference to it being used to treat hemorrhoids. Now, I don't know if that was used as an ointment or you drank it internally with the fact it cheered you up, so you were less worried about them. I don't know. Sigmund Freud, one of the great believers in the therapeutic power of cocaine, noticed that if you take it for stomachache or to relieve indigestion, it would numb the lips. And he passed this observation on to his younger friend, Carl Koller, who at that time was seeking a method of trying to numb the eyeball before performing surgery on the eye itself. And it worked. We have there a picture of one of his patients having an operation on the eye, apparently not complaining and stoically surviving the scalpel. Very quickly, the numbing effect of cocaine solutions was exploited in medicine. Within weeks of the reporting of its use in eye surgery, it was being used for injection in dentistry, and then as a nerve block. Hello. For spinal anesthesia. I don't know why I've got no picture there, but never mind. But there was a problem with it. To numb a tooth for extraction or for filling, you required about 16 milligrams of cocaine. But in some unfortunate patients, 18 milligrams was a fatal dose. The margin of safety was very narrow, and many dentists were frightened by the fact that sometimes a patient would inexplicably collapse and sometimes even die due to an adverse reaction towards the cocaine. Those of us who were synthetic chemists were charged with the notion of coming up with something better, and indeed we did. Alfred Einhorn produced a very popular substitute for cocaine, novocaine, in which he incorporated some of the features of the cocaine molecule that Willstetter proposed. It contains the tertiary amine group, which is there, which matches the tertiary amine group there. It contains the COO ester group, the COO ester group there. So this came out, novocaine or procaine, in 1906 and enjoyed half a century of popularity. I can remember as a 10-year-old having a filling under the influence of novocaine. Although it survived half a century, there's still one or two drawbacks to it. So improved versions were produced essentially post-war. Bupivacaine is on the bottom left and lignocaine on the right. These, again, both have a tertiary amine function, the N there and the N there. But this time they have an NHCO, an amide function, replacing the ester function, the COO of the top one there. We now move to an unlikely chemist, Alexander Borodin, the musician, the composer, who began training in medicine in 1850. In those days, chemists had a higher reputation than being a doctor or a surgeon, so he turned to chemistry after postdoctoral work at Heidelberg, and he published widely in synthetic organic chemistry. He is credited with as the first person to have produced a CF bond. The species benzoyl fluoride was a chemical that he produced. Come 1875, his personal research seemed to have stopped. Possibly composing was taking over, but he still acted as a mentor to several research students. one of whom is this character called A. Drygin. Now, I know very little about A. Drygin, not in his forename or his gender. I know from his single paper with Borodin that he was qualified as a pharmacist, and he did some postgraduate work with Borodin. It's possible that A. Drygin might have been a female student, because from the biography of Borodin, he took an interest in students with unconventional backgrounds, which I suppose in the 1870s and 1880s would include women chemists or pharmacists. What was Drygin's project? What did they do? Well, in 1880, they reported that they had taken urea, CH4N2O, and reacted it with quinine dihydrochloride, complex formula there, to give a one-to-one mixture, a one-to-one adduct, which was C20H20, all that in the bottom of the slide there. But the thing about this was that unlike the quinine hydrochloride, which is virtually insoluble in water, the species, these crystals, these new ones, this adduct with urea, is very soluble and will dissolve in a similar amount of water. 1 gram of water will dissolve 1 gram of this one-to-one adduct. Why did they choose this particular combination, and how might it work? Was it like my chemistry of 1955, where I'd be adding one to another with a hope that something might happen? Or was it that they had perceived that urea is very slightly basic and quinine hydrochloride is slightly acidic, so the two together might have some interesting chemistry? Or could it be that their personal interests of the time? Borodin was moving towards biochemical matters and had an interest in the excretory products in the urine of animals, horses and the like. So that might be his interest in urea. Drygin, being a pharmacist, might well have been fascinated, like so many of the era, with quinine, which was being used for all sorts of purposes in medicine, hair restoring and all the rest. Writing about this about 4 years ago, Michael Jewish, who might well be zooming in today, discovered a paper that said that urea, if you dissolve it in water, raises its dielectric constant. Thus, an ionic material like quinine hydrochloride would have an enhanced solubility in this water urea solution. Doesn't explain the one-to-one nature, but it is a partial explanation of what might be going on. So they have a method of getting a very soluble form of urea. How might it be exploited? Well, some 40 years previously, the hypodermic syringe had been invented, and then by 1900 was commonplace. So they could use it as a means of getting large amounts of quinine into the bloodstream without the inconvenience of having to inject large amounts of water to carry it. Alternatively, you could take it orally, but again, it would be decomposed in the stomach and intestines. It wouldn't end up predominantly in the bloodstream, but with a syringe, it would. My story then goes to Little Rock, which is in the state of Arkansas in the southeast USA, in the malaria belt, because the swampy area there used to encourage the breeding of mosquitoes, and malaria was an endemic disease. We're moving towards the quinine, aren't we? We encounter Dr. Henry Thibault, who was a physician specializing in malaria, and it was unfortunate for him that he was allergic to oral quinine, which was a cure and prophylactic against malaria, but he had now the possibility of getting quinine into the bloodstream without oral dosing by using what I've called Drygin's injectable mixture. And in 1905, he injected some and achieved this as a result. I found that when the second injection was given in the area infiltrated by the first, there was no pain caused either by the needle or the infiltration of the fluid. When more concentrated solutions had been used, this anesthesia lasted from 24 to 48 hours. He had discovered, he thought, a new local anesthetic that might have advantages over cocaine and the recently discovered synthetics. So, knowing that you don't get prizes for coming second in chemical or medical discoveries, he anxiously put it into press that he'd made this discovery, and he listed the operations which he and his friends had used in using the Quinine Urea. The gentleman who was zooming in might like to look at number 5. Chancroids are a form of ulcer, venereal disease, which prior to the advent of antibiotics was difficult to cure. Suppliers got onto the bandwagon and began to market ampules of the Quinine Urea for use in local anesthesia, and I spotted this for sale as an historic product on from eBay about 6 years ago. Now with metprocaine or novocaine, this was the most successful, popular and safe anesthetic, which would from a single injection give you 2 hours of anesthesia. Quinine Urea's advantage was that it would give hours, if not days, of anesthesia. It was also thought that what they call granular fibrin deposited around the injection site might minimize blood loss. I don't know, but certainly the advantage, according to Thibault, was it would give you hours, if not days, of anesthesia. It became very popular for a short time. Here's a quotation from Arthur Hertzler from 1969. So I'll let you read that to yourselves. So Hertzler is using it to conduct amputations, but there's a hint that it might not be the perfect anaesthetic, but it might be, because he talks about failure to achieve anaesthesia, Holter technique, and this problem of necrosis, which again we might encounter later on. The doctors of the day, and indeed the chemists, were happy to inject into the patients substances of unknown composition, and I think we'd have more faith in this as a local anaesthetic if we knew what its structure was. There's no ester group in the molecule. It does contain a tertiary amido group. The N there is tertiary. And when I wrote this slide, I said there's no amido group common to several post-Novocaine injectables. Then about a week ago, looking at these slides, I spotted that urea is itself an amido compound. So the fact that had a urea and quinine formed a one-to-one chemical adduct via the terminal NH2 of the urea, it might well contain an amido group of the post-Novocaine anaesthetics. But was it any good as a local anaesthetic? Hertzler was very, very taken with it, but come the early 1920s, its popularity was dwindling. It wasn't as good as they thought, and there were problems. Did it actually work? Well, this was a question that that was being posed. Experiments were based on the rabbit's corneal touch, where essentially you put in a couple of drops of the anaesthetic test solution into a rabbit's eye, and then poke the poor creature in the eye and see how much it flinches. The observation showed that it was as effective as cocaine at 3%. And if you tweak the molecule of quinine to use, say, hydroquinine or ethylcuprine or the rest, then you can get even more effective and powerful local anaesthetics. It's not the best method, though, of assessing anaesthetic potential. And then we had, in 1942, a very, very damning report on this as a local anaesthetic. Neither a 1% solution nor a 10% one demonstrated any corneal anesthesia. It elicited a violent irritation, seeming to rely on the use of quinine as a cure-all and hence also as a local anesthetic. So they then pursued this further and decided to look at the effect of this product on the sciatic nerves of frogs to see if they would then twitch when subjected to electrical stimulation. And they said the quinine hydrochloride has an anesthetic solution only at the very irritant concentration of 10%, at which point its pH is 2.6. The solution of hydrochloric acid having the same hydrogen ion content is also anesthetic, obviously through irritation exclusively. In concentrations of 1 to 2%, which are used clinically, the drug has no more anesthetic effect than an ordinary saline solution or slightly acidulated water. Well, that's pretty damning, isn't it? But let's go back to the list of operations that Thibault had performed, or his colleagues had performed. Were those patients all numb, or were they so influenced by the, well, psychologically, by the effect of this new anaesthetic that they seemed not to experience the pain. Having a tumour the weight of half a pound removed from one's shoulder with only this form of local anaesthesia, well, all I can say is that the surgeon must have had great powers of suggestions. It didn't disappear completely, because I came across an endorsement from 1961 based on 540 patients who had been subject to its use in dermatology for skin graft operations, and they were these surgeons were very happy with its use. They said especially on people allergic to procaine. And indeed, it is still in suppliers' catalogues. I spotted that again 6 years ago and rang up the company concerned, but they would not reveal how many samples they'd sold in the previous period, who had bought it, or what it was being used for. And I floated this with my co-author, not borrowed in, but Peter Ellis, who is on the right there, a former student of mine from the late 60s. And he suggested that possibly it is used now as a sclerosing agent to block varicose veins and hemorrhoids. Whether or not it is, we don't know, but that was his possibility. But Peter produced a lovely conclusion to this piece of work based on Borodin, so we'll just let you read that. So the mystery remains. Did it work? Did it not work? And if it wasn't working, how come it was being used for a number of operations in the early years of the last century? I have to thank now the University of Derby for research facilities, and to David Zook, whom I mentioned at the start of this talk, who was very useful to me in crystallizing some of my thoughts about where chemistry and anesthesia comes together. And finally, I have to thank Peter, who had the foresight to start these seminars some 3 years ago during the first lockdown to stimulate our interest, and continue for overseeing their continuance ever since. So thank you very much, Peter.
Thank you very much, Alan, for just another wonderful talk on an intriguing subject matter. Anybody looking at that last slide will realise that it was taken a long time ago, back in 2006, about 17 years ago. Hope I haven't aged too much. Anyway, Alan, I took two things away from your talk, or two things I wanted to mention. One is you say that you had an injection of Novocaine when you were 10 at the dentist. I can only say you were lucky. When I was 10 and somewhat older than 10, I went to a dentist who refused to use local anaesthetics on men, including boys. And nobody believed me, but he once gave me a root canal without any anaesthetic whatsoever.
My goodness.
Which I must say was a painful experience. Anyway, so you were lucky to have Novocaine. The second point I was going to make is that you don't mention any dental use of quinine urea. Is that the case?
Well, they tried it, of course, because I suppose the greatest use of Novocaine from 1905, 1906, and in cocaine from 1880 to about 1910 was in dentistry, but in fact, when they tried it, it was not a success. The patients, they said, were disturbed or frightened by the long period of anesthesia it produced, hours, if not days of anesthesia. And secondly, there was a problem. Even using sterile solutions, you'll get a reaction in the gum that would cause soreness and essentially abscesses. So it was an imperfect anesthetic if it worked. And of course, by that time, it was competing with Novocaine, which was exceptionally good. I can remember from my days of having it as a 10-year-old, the fact that it numbed the jaw, or numbed the area, for 2 or 3 hours after the injection. And that's why the more modern ones came into being, the lignocaine, for example, which were as effective in numbing the tissue, but also they wore off quickly. So you were not in the same risk of biting your tongue or the inside of your cheek after the dental operation.
Very good, Alan. Henry Rep has been active and chat, and I'll read out his question. I must say, and apologies, Henry, if I'm sort of appear to be taking part of the credit here, but the same question did occur to me. This question is this: cocaine rather, has 2 stereochemical centers. Do you have any idea when these were correctly assigned? Presumably much later than the overall structure.
No. As far as I know, that I can't produce that information.
Well, I noticed it had about. I noticed it had the cyclohexane ring had a boat conformation. Presumably, Voltaire, for his brilliance, wouldn't have realised that.
That's right. Yeah. Let's bring him up again.
Now, Henry asked another question. I have done a search, and no crystal structure of the one-to-one complex between quinine and urea appears to have been determined. Given
Good,
the property,
excellent.
one might imagine that this looks interesting.
I will say that if we were to, I mean, this will be a lovely area of research again. First of all, to get the structure of this one-to-one adduct. Is it one-to-one, or is it a loose attachment? If it's definitely one-to-one, then we have a molecule there whose structure needs to be determined. So we need to work on that. And it might well have an amido group in it and the tertiary amine group. So it might have potential as a local anesthetic. But then we need to test it properly. Do we need to move beyond rabbits and the corneal test? I think that we've got.
Could you try it on yourself, Hannah? Could you try it on yourself,
well,
maybe?
We've got lots and lots of people serving time in prison for non-violent offences. I'm sure if they were to volunteer themselves as guinea pigs and have perhaps, by virtue of this social service, a week or month or 2 of knocked off their sentence, we will find out whether or not it was effective. I'm not saying chop their fingers off or circumcise them, but you can do little operations to find out whether or not its effect was psychological. Did it work? Did it work for so many hours or days after the injection? So there's still a lot of work. But you see, the trouble was, with the popularity of Novocaine, nobody had any interest in it. So its interest just disappeared.
Yeah, I mean, coming back to the X-ray crystallography, I mean, do you have any facilities at Derby for doing that sort of thing?
No, I haven't, no. And I don't now have access to laboratories either, so I can't volunteer to make some for you.
Yeah. So anyway, so Henry, maybe this is something you could do at Imperial. Say something in chat if you want to, but you've raised an interesting point. Henry also says that crystals of quinine with thiourea are also known, in fact known.
Shall we therefore inject some of that into a patient and see what happens? As far as I know, it hasn't been done.
Yeah. Well, very interesting compound. Well, anyway, has anybody got any final questions before we wrap this up? Just put them into chat and I'll be sure to read them out. So don't worry, I will read out what put in chat. So please don't worry. Any final questions for Alan? Alan,
Well,
thank you very much. Yes, again. Oops, people are just saying thank you, as indeed they should. And I'm going to say thank you too. Thank you, Alan, for another wonderful talk. Maybe again next July, or would you prefer June if it's cooler?
Okay, farewell to you all. I can see a number of my friends from yesteryear have been zooming in. I hope you enjoyed it, and sad that the slideshow didn't work, but I think you probably got enough from the slides. And yeah. let's go back to
ball through. Okay, thank you very much, everybody. And we'll meet you again next month when Vincent Daniel will be standing in for Alan and talking about 100 years of conservation research at the British Museum. So please tune in next month for 100 years of conservation research at the British Museum by Vincent Daniel, and we'll look forward to seeing you again. We end with this lovely picture of Alan Dronsfield as a young boy. What better way to end? Bye for now.
Cheerio.